Alana Miller. I'm a psychiatrist, and I'm going to be talking about healing from post-traumatic stress disorder, covering a couple different things: trauma therapy, post-traumatic growth, psychedelics, and a couple of other things. So it's just me, so hopefully I'm not going to talk for 90 minutes straight. I'll try to go through my slides relatively quickly so that people can ask questions, and also I wasn't able to do the speaker office hours tomorrow, so I'll stay after today in case people wanted to come and ask me personal questions or anything like that after the talk. So just to jump right into it, what we're going to cover, I'll give a little brief intro to my story. So I'm a psychiatrist, but I'm also a 2-time cancer survivor. So I'll talk about how trauma, including cancer, counts as a causal factor of PTSD, leads to PTSD. I'll talk about how to know if you have PTSD, so kind of like the diagnostic criteria. I was really inspired to do this talk because a lot of people, I think, have this idea of what PTSD is from how it's portrayed maybe in film and TV and stuff like that, imagining it's this very dramatic thing, but it really, the subjective experience of it is really more of like the absence of something, like the absence of joy, of full range of emotions, of feeling like you can live your life fully. So a lot of people don't realize they actually have PTSD, and that there's very good treatments for it. So I'll talk a little bit about those treatment options, including trauma therapies and mind-body approaches, medications. I know everyone wants to hear about psychedelics. That's at the end, but I will get there. And then also post-traumatic growth, it's easy to focus on all the ways that cancer and trauma kind of takes away from us, but also people who've had traumatic experiences often experience these really profound areas of growth in their life. And it's interesting, those two things can exist simultaneously. Like, we can both be traumatized and then also have experiences, areas of growth. So, okay, so about me, like I said, I'm a psychiatrist. I practice integrative psychiatry. And I was in my 4th year of psychiatry residency at UCLA. I specialized in PTSD prior to having cancer. In Iraq, Afghanistan vets in the VA in Los Angeles. And then it was my 4th year when I was 6 months away from graduating, and I was diagnosed with T-cell ALL. And that kind of started my journey. I'm not going to go into details now for the sake of time and everything, not to focus on myself, but I did a pediatric protocol, and then was recovering after that. And just fast forward to when I was recovering, and I don't know if people here have had this experience where you've recovered physically, or you're recovering physically, but you still don't feel like yourself and you don't quite know why. So this is what I experienced, and it's funny because even as a psychiatrist who specialized in PTSD prior to having cancer, it took me a second to realize that I myself had PTSD because it was so kind of subtle the way that it affected my life, so I was really socially isolated. I had people who wanted to be my friends, and I was not following up with them or responding to their texts. I was unable to relax, kind of just this physical feeling of not feeling safe, but you don't quite know why. Now, I wasn't depressed, and this is something that a lot of people don't realize. You can be not depressed, but you don't feel happy, and it's actually that absence of positive emotion. That's something that's really characteristic of PTSD. It's I'm not depressed, but I don't ever feel any of that happiness I used to in my pre-cancer life. I'm kind of going through the motions. And it's kind of this feeling that your world is small. And it's kind of comes from avoidance, which can be avoiding people and places and things, and talking about cancer that remind you of cancer, but also your own thoughts. And when you can't go to whole places in your brain because it triggers you, then that's when your world ends up being just this feeling very small. There's less and less you can do, less and less you can think about. And I just put this, I had this illogical belief I would die at 45. I put this down because it's funny. It's like a textbook diagnostic criteria of PTSD, this belief in a foreshortened future. And I'm not talking about if you have a prognosis or something, like a doctor's told you something. This was not logical. I just had this idea in my head. I was 35 at the time. I thought, okay, I've got 10 years left of life. That means I have to do all these things I want to do in my life in 10 years. And I was kind of operating consciously, subconsciously under this belief, and realized, like, wait, why am I doing this? And it's something very common that people who are veterans experience when they come back from war, just this idea they're going to die early. And obviously, as cancer survivors, sometimes it's a reality, you know, but I'm saying even beyond the reality of it, that belief system can be part of PTSD. So the diagnostic criteria of PTSD, I'm trying not to make this too clinical, but I at least want to explain it, because I think when I'll go over both the diagnostic criteria, but also kind of how it feels like when you're experiencing it. So there's 4 categories of symptoms that people tend to experience, and to diagnose it, you have to have a certain number of symptoms in each category. But number 1, in this, first you have exposure to a traumatic event. Everyone here, you know, checks that box. So, but the number 1 cluster of symptoms, intrusive symptoms. So this is like intrusive memories, nightmares, flashbacks. It can be triggered, like something comes on TV, your friend asks you how you're doing, or someone mentions something about cancer, or even maybe stuff at this conference. But it can also just kind of come on out of nowhere, where you feel like you're living it, like again, like you're back there, or you're just, it's like popping in your head and you don't want it to. The real big symptom of PTSD that often really affects people's lives is some form of avoidance. And so sometimes it's obvious, sometimes it's avoiding, like I said, people, places, things that remind you of your cancer. But then it can also be this internal avoidance, like this emotional numbing of, I avoid thinking about it. So if I'm just sitting there and something comes into my head, I try to suppress my thoughts. But then that's actually what leads to the feelings of emotional numbing, is because our brains are not very good at just suppressing the negative. We tend to suppress everything, and so then we suppress positive emotions too. So the category number 3 is negative thoughts and beliefs. And so, you know, it's interesting, to some extent you might be reading this thinking like, well, isn't that logical? Like, life really isn't fair. And that's true. Like, if you've had cancer, you've experienced that, especially as a young adult. But it tends to generalize, like, and that's where it becomes more of like something that affects someone in their day-to-day. So not just, oh, this one bad thing happened to me, but I'm bad, or the world is just this horrible place and these things happen all the time. Whereas it very much can be just, oh no, this one thing happened to you, and otherwise your life maybe is or could be very, very good. So that kind of like generalized negative self-beliefs, definitely like feelings of guilt or shame, it's less, I see that less with like cancer survivors, but sometimes like, oh, I caused this in some way. And then the 4th category is increased physiological arousal. So like irritability, anger, you know, I'm sure everyone here has heard of the fight or flight response. So there's the flight, but then the fight. So sometimes people get kind of into arguments, and it's out of their character, and friends and family don't really understand, but it's because their body's in this really kind of like a sympathetic overdrive state. Hypervigilance, just like kind of like head on a swivel is how I describe it. Increased startle response. So I don't know if people have experienced this, like someone taps you on the shoulder and you like jump, or the phone rings and you jump, like something that's just like an ordinary sound or stimulus, and you kind of have this exaggerated physical response to it. Definitely insomnia is a symptom of PTSD, but then also trouble focusing and concentrating. So, I mean, it's hard because like we all probably have had brain fog and stuff from our treatments, but also it can be a symptom of PTSD where you just can't like focus and concentrate because, you know, adrenaline coursing through your body all the time isn't exactly good for like focus and concentration. So I'm just keep my phone here so I can keep track of time. So on my website, zenpsychiatry.com, and if you just do /PTSD, I uploaded all these rating scales, and a lot of the resources I'm going to be talking about, I just uploaded to that page, so you know you can download them. But there's this PTSD checklist that's commonly used that is like a screening tool, and you can get it from my website and take it if you're curious. Usually the cutoff for a PTSD diagnosis is somewhere between like probably over 33, but definitely over 38 is like very high. I mean, extremely specific for PTSD. So, I mean, like I've kind of gone over the jargony kind of diagnostic criteria, but like, does this subjective story resonate with you? You know, like a commercial comes on for a cancer center, like all those St. John's commercials, I'd be like flipping the channel immediately. Maybe you avoid scheduling follow-up appointments because being in the hospital brings back too many painful memories, like avoidance around some of your medical care. Or if someone asks you how you're doing, brings up your cancer experience, you're like, oh yeah, it's okay, and then you like change the topic immediately. That's kind of that subtle avoidance. Again, like avoiding people or places, suppressing memories and emotions. And again, you're not necessarily depressed, but you're not happy. There's this feeling like life is kind of muted and you feel numb. And I mean, to some extent, you might be asking like, yeah, but isn't all that normal? And kind of yes, to some extent, but I would say if you feel like your daily life is impaired by these symptoms, like your ability to work, to be in relationships, like romantic relationships or your friendships, or just your leisure time and your fun, you can't do it because of these experiences, that's where, like as a clinician, I think, okay, this person has not like just normal, you know, everyday anxiety, but something that can really be helped with treatment. And I guess that's like the main thing. I'm going to transition to talking about treatments. It's very treatable. I see this, I think it's like a misunderstanding, like the way I see people talking about PTSD on social media or whatever is, oh, just my PTSD is acting up again, and this is just how it is. No, there's actually really good treatments for PTSD, and I would say in my clinical practice, it's one of my favorite things to treat because people can get so much better over the course of a couple of months. So it's not something you have to live with for like your whole life or anything like that. But that being said, it requires probably you doing something different than what you're doing now, because to overcome, you know, our fears, we have to face them. And so let me kind of now shift to talking about how PTSD develops. And this has been studied in these really interesting studies looking at these mass trauma, mass casualty events like 9/11 or the 2004 Indian Ocean tsunami, where, I mean, like simultaneously thousands and thousands of people are experiencing a traumatic event. So psychologists and caseworkers and stuff will come in and interview people right after the traumatic event, and then interview them like 3 months later, 6 months later, 9 months later, etc. So all those symptoms I described in the immediate aftermath, and it's actually more than this. I saw research after making my slides where it was like 94% of people in the immediate aftermath have symptoms of PTSD. So it is actually like a normal response in the immediate aftermath. You don't even diagnose PTSD until it's been a month that someone's had those symptoms. But often, even after a month, like it goes away on its own. But when you're talking to people, say like months later, 6-9 months later, only 30% have PTSD. And I would say those are the people who actually like have PTSD rather than like an acute stress disorder. And so the question is, what's the difference between the people who recover and the people who don't? You can almost think of PTSD as like a failure of recovery, and I don't mean failure like a moral failure or something. I just mean like an absence of recovery. So why do people kind of get over it and move on with their lives, and other people are stuck with these persistent symptoms and this persistent, effect on their lives? And it's kind of like a complicated answer. You could talk about things like genetics and early life experiences and stuff, but to the degree that what's under our control is one thing, and that one thing is avoidance. So there's, it's interesting, the very strategy we use to try to feel better is actually what perpetuates, sorry, I have to take a sip of water here, perpetuates the PTSD and makes it go from an acute stress disorder to PTSD. So like a little thought experiment, I do this with all of my patients when I'm explaining why we're going to do exposure therapy. So imagine you have like a niece or a daughter or your little sister or something, and then she's at the park one day and just a total freak accident, she's bitten by a dog. And it's never going to happen again. This dog was just a stray dog there randomly and got taken up by the pound, and it's fine, it's not going to happen again. But now she's terrified of dogs, and then it generalizes. So now she's, even though it was just this one dog in this one park in this one day, she won't go to the park at all. She also won't go to her friends' houses who have dogs. She doesn't want to walk to school anymore, because to walk to school she has to pass by like a yard where there's a dog in that backyard. And so my question is, like, what would you do to help her? And you don't have to say it out loud, but just think like in your mind for a second. Actually, I'm just out of curiosity, maybe does someone want to shout out what they would do to help? Yeah.
Exposure therapy?
Yeah, exposure therapy. Yeah, like, so, you know, people say like, oh, I'd get her a puppy, I'd take her to the pound, I'd have her play with a cute little like golden retriever and show her dogs are okay. And like, notice what you didn't say. You didn't say, oh, I would like, you know, help her move to a different town where no dogs existed. I'd help her like find new friends that didn't have dogs. Like, it's so obvious that that would create like a huge problem. If we were to do that, you'd be creating an anxiety disorder. You'd be teaching her like, oh no, this is really scary. You should be just scared all the time, and I'll help you avoid it. No, you'd help her show her it's okay. So there's two things there that everyone kind of gets that intuitively when I tell that story. One is, to overcome our fears, we have to face them, but you also, to be successful, do it incrementally. So, like, you wouldn't take your little niece and then put her with a Rottweiler and expect that to go well. You know, you start, like, in an area where she feels just slightly anxious, and then build her confidence, like, oh, actually, I handled that better than I thought I would, and then she gains more confidence in new situations. So I'm going to kind of shift for a second before I go back to trauma therapy and how that works, and just talk about post-traumatic growth. You know, again, like, the two things can exist simultaneously. Like, you can have PTSD and you can also have post-traumatic growth. And there's been really interesting research by this group, Calhoun and Tedeschi, that have come up with this post-traumatic growth inventory I'll show in the next slide. But there are all these areas where when someone has gone through a really difficult experience, they grow in a lot of profound ways. I mean, just realizing your own personal resilience, like, oh man, I got through this thing, and maybe feeling like there are new possibilities open to you, like even people who are cancer survivors and now work in the cancer world and help others. Improved relationships. I'm sure we've all experienced the siloing that sometimes happens with relationships when you have cancer. Like, some people don't show up for you, other people really show up for you, and it hurts the people who don't, but then it's really nice, those people who really do, and kind of a strengthening of your really solid relationships. You know, spiritual growth, appreciation for life. Like, I don't know about you, but my sense of, like, my opinion of what is a problem has really changed after having cancer. You know, just things that other people consider problems. I'm like, no, that's not, like, no, I mean, not to say that that's not their experience, and I don't judge anyone, but it's nice for me that I don't get stressed so easily by things that other people often get stressed by. So this is the post-traumatic growth inventory that I mentioned. It's also on that, on my website, with that Zen Psychiatry /PTSD, if you wanted to take it and kind of see what the questions are. Okay, treatment options for PTSD. So I'm going to briefly talk about medications, just like regular psychiatric medications, talk about trauma therapy, then mind-body approaches, and then I know everyone wants to hear about psychedelics, so I'll talk a little bit about psychedelics. So, and I don't know, like, I speak to different audiences, so what people's just like general opinion is of psychiatric medications here. Like, I practice integrative psychiatry, and a lot of times people mistake that for being alternative psychiatry. I don't practice that. So I do therapy and teach mind-body approaches and use supplements and stuff, but I prescribe medications quite a bit. Like, they help. And I hate seeing in my clinical practice, like it just pains me as a woman who wants to be a healer, when I see someone not consider prescription medication because of an idea they have about what it does rather than the reality of it. And people attach so much shame to psychiatric medications in a way that they just don't with literally any other medical condition. Like if you have type 1 diabetes, you'll take your insulin shots. There's no like, oh, I should be able to do it like myself. And or if you have, like hypothyroidism, you take Synthroid, or you have appendicitis, you'll get an appendectomy. But for some reason in our culture, I think there's just like a lot of stigma. I mean, against mental health, but I'd say there's more stigma against psychiatric medication. So even people who are like, yeah, I do have anxiety, I do have depression, still won't let themselves go there with taking prescription medications. But from my perspective, as someone who practices in the integrative space, taking medications is congruent and complementary with doing therapy. And the way I describe it with my patients, it kind of like, and I'm talking specifically about the SSRI class of medications, like I list some of them here, you can read it. But they kind of turn down the volume of the anxiety and make it therapy more effective, because the exposure therapy that I'll be talking about is not easy. I mean, to do the exact opposite of what like the human impulse is, which is to avoid things we're terrified of, is kind of what you have to do in therapy. And a lot of people won't ever even consider the therapy because it sounds too hard. So sometimes the medications are what allow you to actually face these things in therapy and have these corrective emotional experiences where you feel like you're like more efficacious, like you're able to handle it. I'll talk about cannabis too. I put benzodiazepines avoid. Now, this is specific to PTSD. So benzodiazepines are like Xanax, Ativan, Klonopin, Valium, things like that. And definitely they're very useful in, cancer care and psychiatric care for various reasons. I just mentioned specifically to PTSD, and I'm really speaking about using them every day rather than like a once in a while thing. The reason is that anything that prevents you from feeling anxiety is like an avoidance strategy, ends up perpetuating the PTSD. And that's why I put cannabis here too. And cannabis has a lot of medicinal uses. And I would say like CBD, for example, there's tons of good research for, pain conditions, but within psychiatry for anxiety. But specifically for PTSD, if you're using cannabis in a way that is like avoidance, so that you feel like, oh, I can get through the day like as long as I'm using this. That's the kind of stuff that kind of perpetuates this idea that I'm okay as long as I just avoid and like using a substance, whether it's alcohol or cannabis or benzos or whatever. And I say this without any judgment of using it or not. I just more, it can be something that perpetuates the PTSD. So just some mind-body approaches before I get into the psychotherapy piece of it. So like, I mentioned the fight or flight response, the sympathetic nervous system, and that's not like you come across a bear in the woods and you're terrified and adrenaline is coursing through your body. Think of that as like the gas pedal. So PTSD is both too much gas pedal, but also not enough brake pedal, and the brake is the parasympathetic nervous system. It's the other part of the autonomic nervous system. It's like the rest and digest. So people have probably heard of the vagal nerve, or maybe some people have heard of it, but it's the main nerve of the parasympathetic branch of the autonomic nervous system. And this is why breathing exercises are so useful, because you both want to know how to like take your foot off the gas, but you have to actively train yourself to put on the brake too. And because like the breathing is both something that is unconscious, like if you don't think about it, you'll keep breathing. but it's also conscious if you want to bring attention to it. Like, I can control my breathing with active intent. And so it's really the only organ system in the body that is controlled by both of those two nervous systems, voluntary and involuntary. So doing these deep breathing exercises is a really good way for you to train yourself to relax and to increase the parasympathetic tone that rest and digest nervous system. But I list some other things here too, because also just like pick one, like whatever resonates with you and that you'll do. Just have some activity that you do that feels like relaxing, and you train it like a muscle the same way you train any other muscle. So sometimes I'll teach these things to my patients and they'll say, oh, like it didn't work. I'm like, well, when did you use it? Like right in the middle of an extremely stressful situation. And that was like the first time they tried it. It's like sprinklers on a house fire. You kind of gotta practice the strategy when you're relatively relaxed, and then you can call upon it in a situation where you're more stressed. Progressive muscle relaxation is really good. You can get like guided meditations on how to go, you're kind of sequentially tightening and relaxing all the muscles in your body. I think on like the Calm app and Headspace, all of those meditation apps have progressive muscle relaxation talks and guided meditations. And then heart rate variability training, it's just kind of like a fancy type of biofeedback. It's not even that fancy. You can buy these devices, like HeartMath is one company that has them, but I think there's lots of companies even on Amazon. And it just is, shows you, heart rate variability is a sign of your body being able to move flexibly between parasympathetic and sympathetic. And so it's actually just measuring how much your heart rate varies based from the in-breath to the out-breath. It's really not more complicated than that, and bigger is better. Like more heart rate variability is better, and it predicts positive health outcomes with heart disease and all sorts of other stuff, anything stress related. But it's cool, like HeartMath has these little devices, you just hook it up to your ear. I think one you can hook up to your finger, and then you watch on an app like this little like breathe in, breathe out thing, and it will show you what your heart rate variability is. It gives you like green if it's really good, and blue if it's not so good, and like red if it's not good in that moment. And it gives you just that moment-to-moment feedback to help you do your breathing exercises more effectively. And then, of course, like exercise, I won't belabor that. You guys know exercise is good. But particularly for PTSD, exercise that has like a mind-body component to it, and that it's not stressful, it's like relaxing. Okay. Oh, and just two other kind of interesting things before I go into the therapy piece. There's this thing, cranial electrical stimulation. There's two companies, there's probably more, but these are the two main companies that make these devices. They're home devices. They're expensive. You need a doctor's prescription for them, like they're a couple $100. But the VA has done a lot of research on using these office devices in vets, and it's really simple. You just hook up these little things to your ears. It puts like, they're battery powered, it puts a very small electric current through you, and I don't know exactly what the mechanism is, but people describe it as really relaxing, and it's used for insomnia. I sometimes will use those devices for my patients for who are having trouble sleeping, and it's like a non-medication way to kind of help you relax. The stellate ganglion block, it just is just kind of interesting from like a theoretical standpoint, and I think now you guys understand a little bit about the sympathetic nervous system. It might be interesting to you how it works. This is like, I would say, it's not first line. This is like third line. You've tried other things first and you really have severe PTSD. There's a stellate ganglion block. It's actually done for pain relief, and now it's more recently being done for PTSD, but it's essentially a nerve block on the stellate ganglion, which is the main ganglion of the sympathetic nervous system in your neck. So they put like a little needle in there. It's under ultrasound guidance, and they do a nerve block. Now, the nerve block only lasts a couple hours, but it's really interesting. It just like, so basically just blocks your fight or flight response, and even after the nerve block wears off, people have lasting benefits in terms of lowered anxiety that, like in research studies, lasts like months, if not years. Sometimes people get like a follow-up injection, but just kind of an interesting, it's kind of like a mind-body approach, because by blocking the physiological arousal, people can go into situations that would have caused a lot of anxiety otherwise, but they don't have anxiety, and then their brain kind of rewires, like, oh, actually this isn't so scary. All right, so now I'm going to shift to the psychotherapy perspective, and for full disclosure, I personally am trained in prolonged exposure, so that's like my theoretical, or my, not theoretical, it's like my actual orientation, like what I was trained in. But all of these therapies that I mentioned here, especially cognitive processing therapy and EMDR, are evidence-based, and then these narrative exposure therapy and written exposure are kind of like newer, but have some decent evidence for them. I would just say, like, one caveat with EMDR is because very few people, I think, have heard of prolonged exposure. Probably everyone or most people have heard of EMDR because it's so much more popular. Not like there's a lot of clinicians who say they do it and aren't actually doing the real exposures that happen with EMDR. They're just kind of marketing themselves as an EMDR therapist. So just when you're seeking out your therapist, whatever kind of therapy you're getting, just make sure that they're doing like actual exposures, and they're doing like manualized EMDR, because that's the kind that works. And trauma therapy is about correcting maladaptive learning. So like, I'll just tell this very brief story of a patient I saw when I was at the VA, and this was a guy who had panic attacks as part of his PTSD. And by the time I saw him for an intake, he was like, oh yeah, like I don't have PTSD anymore, I haven't had a panic attack in years, I'm all better. I'm like, oh, that's great. I mean, like he had been referred to me, I guess, earlier. I'm like, oh, that's great. Like, well, how did you accomplish that? He said, oh yeah, like I just don't leave my house anymore, and I quit my job, and like my girlfriend broke up with me, but it's cool. And that's like the maladaptive learning that happens. Like, yeah, this guy had no panic attacks because he was avoiding every potential trigger, and at what cost, right? So you really want to do the opposite. You want to force yourself to do the thing that you're afraid of, and then it's hard, but not as hard as you think it's going to be, and then you get through it, and you're like, oh, actually, yeah, I did that. Now I can do that again. And then, like, so I personally had prolonged exposure therapy, like, on me. Like, I saw a therapist to get it for myself after I had cancer. The first time, I relapsed later, but after the first time. And yeah, it's like hard, but it's incredibly effective, like very, very rapidly. And I might not do all of these slides in like incredible details, but let me just kind of go over how it works, because I think actually for many people, you can kind of do it on your own. I mean, it's great to have a therapist, and if you have like more serious symptoms, definitely get help. But when you understand the concepts, I think you'll start to see it's something that, like, on your own you can do. So the first step is you come up with like a list of the memories that are the most painful memories of your cancer experience. And the reason I say plural, because for someone who has like a single event trauma, like one thing happened to them, it was this one day, this one thing happened, it's pretty straightforward. You just do exposure sessions for that one thing. For cancer, I mean, you probably have a dozen memories of like the time you found out, the time, you know, you thought you relapsed, the time you were waiting for the scan, the time you were hospitalized with a neutropenic fever. So you're kind of putting down all of those memories, and then you're also writing down or noting, like, what are all the situations or places that you're avoiding because of your anxiety or your PTSD, like places you don't go anymore, people you don't see anymore. That's all stuff you're going to want to face, but you organize it into a hierarchy. So there's this thing called the SUD scale. It just stands for Subjective Units of Distress Scale. It's like a 0 to 100 scale of how hard is this, how distressed do I feel. So you kind of order things from like, okay, this is a 50, this one's a 60, this one's a 90, from like, I wouldn't say best to worst because none of them are good, but like least worst to worst. And, you know, like, it's interesting, when I learned how to do prolonged exposure, I was taught to start in the middle and work your way up, and that's certainly, you can do that. But then when I received prolonged exposure, my therapist was like, no, if you're game, let's start at the worst and work our way down. And that's actually what I do with my patients now. And the reason is, if you just start with the worst, and you're willing to do it, and it's like a rip the Band-Aid off, you often don't even need to do the lower memories, because you're just like, it generalizes in the same way PTSD generalizes in the reverse direction when you get it in the first place. If you just face that very worst memory that you like can't think about, you may find that just everything else all of a sudden is much easier. So, like, just the logistics of how specifically you do an imaginal exposure, you kind of want a memory with like a clear beginning, middle, and end, like a time period of like, okay, it starts here, and then this is what happened, and then this is the end. And the end is not like, I mean, the end is kind of when you start to feel like you're coming out of this situation. So maybe, gosh, I'll tell you like what my worst memory was I had this rare side effect from a nausea medication called dystonia. And all it was my jaw froze. But what it felt like at the time was like my jaw I was sitting there and all of a sudden my jaw just clamps shut. And it's squeezing so tight that I thought it was going to crush like, my teeth in my mouth. And then I couldn't breathe either. And so I can't open my mouth, so I can't speak. And then I also am like so anxious and freaking out, so I'm hyperventilating, and I'm like barely able to breathe through my nose. So then it was like, I was living at home at the time. I run to my parents. I'm like trying to tell my parents what's going on. We go to the ER. It takes a couple hours. They figure out it's dystonia. They give me Benadryl. It goes away immediately. And so the second I get the Benadryl is when the memory ended, in terms of doing the exposure. And there's this, I put this on my website too. This is the exposure recording form that I use with patients when I'm doing these in session, because you kind of want to track like your expectations of what you think it'll be like to do the exposure, because people often have these fears of like, oh, this is going to be horribly difficult, and it's going to make me feel worse and all this stuff, and so you make predictions like, oh, I'm 90% sure it's going to make me feel horrible and it's going to make me worse, and then afterward you ask yourself like, did it happen or not? So that kind of is part of what helps, crack the maladaptive learning. And just the logistics, I don't want to belabor it too much. I can stay after and answer questions for people who want, but when I describe this part, is I see people starting to cringe, and that's how you know it'll probably help you, is if the idea of doing this sounds horrible. So you record it like on your phone, you close your eyes, and you describe the story in sequential detail as if you're reliving it in this moment. Present tense, using all your senses, as if you were like writing the scene of a novel or a screenplay or something like that. And the idea is you feel like you're there in the moment. I know that sounds awful, right? It's like the last thing you would ever want to do. But that's where your brain starts to realize that the memory of the event is not the same thing as the event itself. The event itself was dangerous. The memory is just a memory. And when you can face your memory of like the worst thing that happened to you, you can face like anything. It's an incredibly empowering experience. And so my worst fear was to relapse. And I did this prolonged exposure therapy, and I did it over the course of like 4 or 5 months, and then I was like way better. And then I relapsed like 3 months later. And if I had not done this therapy, oh my gosh, I don't even know how I would have emotionally survived my relapse. But like, when I relapsed, I was like, my prognosis was way worse than it was the first time with my type of T-cell ALL, and I had to go to stem cell transplant and stuff, and I'm adopted, so I didn't have any family donors, and I'm like 2 different random ethnicities, and that made it hard to find a donor, so I was like, do I even have a donor and all this stuff, but I handled it like 1,000 times better than I handled my first diagnosis, and it was only because I had this really positive experience of facing these difficult fears and realizing like, oh man, I can really like handle anything. So I'm going to skip this just because I don't want to. The in vivo exposure is just, as opposed to doing an exposure related to the memory, you're doing an exposure related to something in real life, and it's the same thing. It's just like, oh, you're afraid to set up your doctor's appointments. I'll have people go just without an appointment, tell them, as long as it's not going to be awkward or weird, like just sit in the doctor's office for an hour and just to kind of feel the anxiety, and then they leave. So wherever the places are that you're avoiding, you don't have to like go watch a cancer documentary or something like that. It doesn't have to be that specific or like doing it, but it should be things that if you could do them, your life would be better. You know, like being with people that you're avoiding, having conversations with people that you're avoiding. Maybe it's like opening up to a friend you haven't opened up to about your cancer experience and sharing what's really going on with you. All right, now the part everyone wants to talk about. So I have to say the caveat, which is that only ketamine is legal right now. MDMA and psilocybin are in like clinical trials, but I'll explain how all of them work and everything. So ketamine is legal, it's FDA approved for treatment-resistant depression, and it's is an intranasal spray called esketamine, but it's widely used off-label to help with PTSD. And the reason I'm talking about this at the end after explaining all the trauma therapy stuff is because it's not like you just take some ketamine or some MDMA or psilocybin or something and then you don't have PTSD. You use these substances in order to be able to do exposure therapy more effectively. So like I'm sure as I was describing how to do exposure therapy, that sounded horrible, and the benefit I think of using psychedelics is that it makes it easier to face these memories that are really difficult to face. And actually, like the mechanism through which they work, it seems to make people's brains more plastic. So I'm sure people have heard the term neuroplasticity, just kind of makes your brain more pliable so that you can correct that maladaptive learning faster. And I guess, like, let me just be explicit what I mean. So the learning might be from like, oh, I can't handle this, to, you know what, cancer happened to me, but it was just this one thing, and I actually have a bright future in front of me, and I have other good things in my life, and I can handle this, and I have other things to look forward to, as opposed to the world isn't safe, I'm just gonna get cancer again, there's no point in trying. Like, so that positive shift in thinking is made a lot easier with using psychedelics. So ketamine is used for like ketamine-assisted psychotherapy. I mean, sometimes they do these sublingual, like under your tongue lozenges. Sometimes it's like intravenous infusions. Like it's not that difficult to find someone who does ketamine-assisted psychotherapy. That's pretty widely available. Now, MDMA is in phase 3 clinical trials. That's like the last phase. It's probably going to be FDA approved next year. So it's not that far away. I mean, it's like maybe the end of next year, and who knows with the FDA and stuff, but they've had amazing results in the clinical trials. This is via MAPS, the MAPS organization. And so now psilocybin's probably a few years behind that. It was granted breakthrough therapy status by the FDA for treatment-resistant depression, and it's also used for end-of-life anxiety in research settings. Now, that being said, like if I were to relapse and I was going to die or something, I'd find myself some psilocybin pretty quickly. Like, I don't care if it's just research settings or whatever, because it's very useful for that. And again, like it makes it easier to face the difficult memory. So instead of like months of therapy, you know, I told you I did like 4 or 5 months of prolonged exposure therapy. The same process can happen in like 2 or 3 full day sessions. And I do think it's the future of treatment of PTSD, you know, because like it's not easy doing like that long of therapy. It's really hard therapy. Not a lot of clinicians are trained to do it. And I think like I'm hopeful that psychedelics will be widely available like in the not too distant future. Let me just describe, is it in the later? Yeah, let me talk about psilocybin in particular. And I'll kind of describe a little bit about the actual process of what they do in the research studies, and you can take from that what you will, of how they do these exposures. So psilocybin, everyone talks about microdosing, and my patients are constantly asking me about microdosing, and it's really interesting because like in clinical studies, microdoses are the placebo controls. It's definitely not, like if you're microdosing, you're kind of like not really taking enough for do something. I was always, and maybe someone can tell me after, kind of curious why people microdose, like what people feel I think it helps probably for depression, but it's not something you can take every day. And then microdoses, I'm talking about raw mushroom now, sometimes it's like 0.1 to 0.5 grams, and people will do these varying protocols, like 5 days on, 2 days off, 3 days on, 4 days off, every other day, like not daily. And like again, it has antidepressant effects, but it's not going to be enough to help you have like an insight type of experience that's going to allow you to kind of overcome your PTSD. Like to me, if you're going to do it, like just do like a solid dose and just do it once, you know, maybe you do it 6 months later or something like that. But it's the larger doses, and I put 10 to 25 milligrams of the active ingredient, but that about correlates to 1 to 2.5 grams of like the raw mushroom. I mean, it varies by mushroom, but that's like about equivalent. But actually, I probably need to update this. It's really like 2.5 is what they're using in the research studies, or 25 milligrams. They dose it by weight, but like even up to like 3.5 in some studies. And what people do in the studies is you start off with like an intake session and just kind of clarifying the diagnosis and kind of doing some prep work. And the prep work is so this is how I describe it. Like I put some benefits of like psilocybin here. That's kind of clinical terms, but a good way to describe it, it helps you gain access to the most enlightened form of yourself for 6 hours. And so just think of everything you would want to ask the most enlightened version of yourself and have be answered. So I personally have done this, and I'm not sure how much detail to go into. I'll go into some detail. You know, when I relapsed, I found a donor, and I had my stem cell transplant and everything, and I was doing fine. But in that immediate aftermath of my transplant, all I was doing every day was just thinking it was going to relapse. You know, like the relapse risk is like really high in that first couple of months, and I was just so hyper vigilant. Like it was a chest tumor for me, and so like I would just breathe all the time. Like, is it there? You know, like checking constantly if I felt a tumor, any little like pressure in my chest, I'm like, I'm dying. Okay, I gotta prepare mentally for dying. I was just like every day. It was like total torture. And I was like, I need some help beyond like, just therapy at this point. And so I got some advice from a physician about how to do this and the dosing and everything. And what he told me was like, write a list of questions that you want to answer while you're using it. And for me, there were questions from like kind of banal things, you know, like I was writing a book, like what should I do in this chapter of this book? Or, you know, like, well, I'm asking questions, so I might as well ask everything. Some of it was like about family, like how do I process these issues in my family? But some of it was like how do I accept that I may die, and that could be in a month or it could be in 40 years, and I don't know. And, or I even asked, like, what happens after we die? You know, I was like, if I know in that moment, I'm like, why not get the answer to that? And I got answers to all those questions, you know? And like, for me, what I realized was, I realized one really interesting thing, which was that if I were to relapse and to die, that would actually be the saddest for my husband and my family, rather than me. And because I'm a clinician, but my work is really, it's like a calling, it's not just a job. My role in that situation would be to help other people process my own death. And that sounds maybe strange, but that really helped me feel like I would have a purpose even in that, if that worst case scenario happened. Now, thankfully it didn't. I'm 2.5 years out of my transplant, and everything's going really well, but I came out of it with a tremendous amount of peace. And the answer to the question of what happens after you die, the answer I got was it doesn't matter, because how does it change what we do now? And I was like, oh, I could just wait until that happens, and then I'll find out. So, what was the other thing I was going to say about it? And that leads me to the next part. The other really important part of these experiences is the integration work. So in the clinical trials, they'll have a sitting session. This is true for MDMA and for psilocybin. They'll do these 8-hour sessions, usually with 2 sitters, one clinical, one non-clinical sitter, but very non-directive. People are wearing blindfolds, they're listening to music, they're just lying down. People with psilocybin can have nausea, so it's recommended not to eat a lot beforehand, maybe just eat something very light. But then, very interestingly, that neuroplasticity I mentioned, it lasts weeks beyond when the substance wears out of your system. They've studied this on functional neuroimaging. So, the MDMA and psilocybin lasts 6 hours, 4, 6, 8 hours, a little bit longer for psilocybin, closer to the 6 to 8. But the neuroplasticity, that opening of your mind and that pliancy and flexibility lasts about 2 weeks after. So you're really in this state for several weeks to integrate these new experiences into your everyday life. I described, so I used to be really into meditation. I don't do it so much now, but I would sit silent meditation retreats. I remember after doing this 7-day silent meditation retreat, I was oh man, that was 6 months of therapy in a week. That was amazing. And then I did this, and I was that was 10 years of therapy in one day. So it's a lot. It's not the kind of thing you want to do every month or something, but I think they're really powerful. Now, let me just say some caveats here. They're not innocuous, harmless substances. I mean, people do have bad experiences sometimes on psychedelics, not typically in the research setting. So set and setting is really important. If you're in a supported environment with it have some clinical professional help through it, it's going to make it much better, because you may face things that are scary, but if you're doing it in the right setting, you'll gain a sense of efficacy that you're doing it, rather than just be terrified. So it's not the kind of thing that you just take some mushrooms and go to a rave or something like that. That's going to be when people are having more traumatic experiences. But in the research, clinical settings, people are, it's the effect size that is happening in these studies is just astronomical. It's amazing. I was just at the American Psychiatric Association annual conference a couple weeks ago. That was in New Orleans, and so I saw the head of MAPS and the guys at Johns Hopkins that are doing all this research, and it's just beyond anything else we have in psychiatry, how much better people get. So it's really exciting. And I think that's really the end of what, again, all of these resources are on the website. I just put lists of, if you want to find a therapist, who does prolonged exposure. You can go to the Beck website, Psychology Today. There's this book that I highly recommend if you're like kind of a self-starter and might want to do this type of therapy to yourself on your own, is the Reclaiming Your Life After Traumatic Experience workbook. It just basically like goes over everything I explained, but a lot more detail with all the worksheets and everything. And again, it's like, it's all complementary. All the mind-body stuff, the prescription medications. Let me just add one last thing about the prescription medications and psychedelics. So this is the other reason why I think microdosing is not as useful. So any SSRI is going to block the effects of psilocybin and MDMA. It's not dangerous. It's not going to like cause some like crazy reaction in your body. It's just going to make it not have any effect because of the way that it interacts with the serotonin receptor, transporter receptor. So like with patients that I've had, and again, I can't like recommend this with my patients obviously, but patients who are going to do it, I can help kind of talk with them from like a harm reduction standpoint about how to work with like their psychiatric medications that are maybe very beneficial. But we can do things like skipping some doses or lowering the dose if it's appropriate in anticipation of the experience, and maybe skipping like a couple days beforehand. But microdosing, it just means you can't take an SSRI, and SSRIs really are, I mean you could, but then there's no point to microdosing. And SSRIs are like really helpful. So that's just something to keep in mind if you are on an SSRI or considering it. Don't not do it if you're interested in psychedelics, because there are kind of ways to work around it. In the research studies, they are screening out people on SSRIs, but that's research. So we will in the future have to figure out how to work with patients who are taking them and who benefit from them, but maybe want to have these experiences as well. So last slide, how to get help for PTSD. I mean, number one is just change your relationship with fear from like, this is something that I should not do, to, oh, if I'm afraid, I should definitely do this. Like, that's the way I think about it. I'm scared of something, I'm like, oh, I should definitely do this thing. And then find a therapist who specializes in trauma-focused therapy. And then, find a psychiatrist who can help with medication support if you need it. So